Good morning to all of you. So, we welcome you all for this month clinical meeting, going to be presented from the Department of Plastic Surgery as well as from the Department of Rheumatology. The first talk is going to be from Dr. Bhagavath Kumar sir on carpal tunnel syndrome.
Good morning. So I chose this topic, which you can say is a relatively simple topic, which I think most of you must have heard. And looking at the audience here, there are senior doctors, there are junior doctors, there are senior nurses, junior nurses. So I thought something which is relatable for everybody, easy to understand, simple topic. Not use too many technical words and confuse everybody in the morning. So I chose this topic. Another reason I chose this was as MBBS students, you might remember the first day we go to the anatomy dissection hall and dissect the hand. And even the anatomy book, the first chapter is on hand. And when you read the anatomy, there is a small thing called applied anatomy at the end of the chapter, in which they mention the diseases. And the first disease is mentioned as carpal tunnel syndrome. So in fact, for me, the first disease I ever heard after entering MBBS was carpal tunnel syndrome, probably for many MBBS doctors. And if you look at it that way, okay, so let's start with the topic. What is carpal tunnel syndrome and how we go about it? So basically, it's the compression of a median nerve. So it's a simple compression of the median nerve. Before we go into that, we need to know what is carpal tunnel. So what is carpus? In Latin, the wrist is called carpus. So the wrist is carpus. Okay. So there is a carpal tunnel. The tunnel is formed by the carpal bones in the dorsal or posterior aspect, and on the front or the volar aspect you have the flexor retinaculum, which is called as transverse carpal ligament. So this is a tight ligament, and below you have bony structures. So that forms a tunnel. Okay, so a tunnel is a enclosed structure through which structures pass through. So as you see in this diagram here, this is the area of the carpal tunnel. You have the transverse retina skin, and then you have the palmar fascia, and then you have the transverse retinaculum. And if you see the cross section, you have the bones, the carpal bones, the wrist bones, and then you have the transverse carpal ligament. And going through that is all these structures. Okay, so what goes through these structures? So everything that goes from the forearm to the hand go into these structures, except for some of them which I'll mention. So you have the flexors for all the fingers. So there are 9 flexors, 2 for each finger and 1 for the thumb. And then you have the median nerve. All these go in the carpal tunnel. There are some structures which go outside the carpal tunnel, like you have the median nerve, the ulnar nerve, which goes outside the carpal tunnel. It goes through another canal called the Guyon's canal. So we won't come to that. Okay, so far you're clear what is carpus, what is carpal tunnel, what are the structures which go there. So as you see in this, there are a lot of tendons, and then there is a median nerve, and the compression of this nerve is what causes the carpal tunnel. So if you look at the population, it's usually in the 50s that they start manifesting. So it's not a disease of children or young adults. It's usually the older adults, and it's more prevalent in the female population, and the general prevalence is about 3 to 6%. So what causes this compression? So it could be various causes. The common cause which we find in our practice is physiologic compression. So what is physiologic compression? As I mentioned to you, it is a tunnel. It's a tunnel which cannot expand. You have a rigid structure on the bottom, you have a rigid structure on the top. It cannot expand. So when the contents of the tunnel expand, there is going to be tension. Okay. So what can cause this increase in compartment pressure? So that could be an inflammation, diabetes, all these, hypothyroidism, all these factors are fluid. They retain fluid. So when you think of a tendon as a wire, and then you have a tendon sheath going around it. Now the fluid accumulates in these conditions like pregnancy, diabetes, hypothyroidism, rheumatoid arthritis. And because of that, these tendons become bigger in cross-sectional size. So as they become bigger, they press onto the median nerve. So you should remember clearly that this, even though the problem is the median nerve, there is nothing per se wrong with the median nerve. It is the other structures, that is the tendons, which are pushing onto the median nerve, which is causing this compression. So physiological factors I mentioned. Anatomic factors, common wrist fracture. Suppose you have a road accident and you have a multiple wrist fracture, the bones go into the carpal tunnel and can cause an acute carpal tunnel syndrome. And what causes all this is ultimately occupational. So when you talk about occupational, there are some occupations where you have a repeated motion. For example, somebody who's breaking the roads with a drill, they continuously do that vibration motion. The whole day they are doing that for the whole life. These are the people who can develop carpal tunnel syndrome because of an occupational hazard. So now what happens here, whether it's anatomic or physiologic cause, whatever cause it is, there is an increase in the pressure within the carpal tunnel. That's called the increased intracarpal pressure. So as I mentioned, as the pressure increases, it pushes on to the median nerve. So that compression causes problems with the median nerve. So you should remember that there's the anatomy of the nerve. So the compression first affects the blood supply to the nerve. So there is a blood-nerve barrier breakdown, which causes the edema, and this is the early stage. But as it progresses, there is a demyelination, and the nerve conduction is affected. And in the late stage, there is total destruction of the nerve in the form of an axonal loss or a degeneration. And this can lead to a permanent motor and sensory loss. So how do these people present? So if you remember, there are three nerves going to the hand: the median nerve, the ulnar nerve, and the radial nerve. And they all have different areas of innervation and different motor functions. So since the median nerve is passing through the carpal tunnel, all our symptoms are going to be related to the median nerve. So there is going to be paresthesia. Paresthesia means altered sensation, that is numbness or tingling, and this can be felt in the areas which are innervated by the median nerve. So usually the small finger is spared. Then there is something called as nocturnal pain. Nocturnal pain is typically the patient says kai tunga poirudhu அப்படிம்பாங்க. That means the hand goes off to sleep. They don't feel the hand at all after some time. When they are sleeping in the night, they wake up, they don't feel their hands. Sometimes they wake up with severe pain in the hand. So that is the nocturnal pain. And as it progresses, there is a weakness of the thenar muscles, which causes weakness, in which because of which they have difficulty in grasping objects, putting buttons and other things. Note that the little finger is spared because it's the ulnar nerve which innervates that. So clinical examination to diagnose carpal tunnel, we have various tests. The three simple tests are the Phalen's test, Durkin's test, and the Tinel sign. So the Phalen's test is you ask the patient to hold the hand like this. So you're acutely flexing the wrist, and you hold it like that for about 30 seconds. The symptoms start reappearing. Same thing with the Durkin's test. The Durkin's test, you press over the transverse carpal ligament, give pressure there so that the symptoms are exaggerated. And the Tinel sign is when you tap on the hand and there is a electric shock passing through. So it need not be here, it could be even further distally, or it can be even proximally if it is a late case. So these are the clinical signs that can be elicited in the clinic. Then the most important thing is you look for the thenar muscles. The thenar muscle is the bulge that is seen in the thenar aspect of the palm. If you see a late case of carpal tunnel syndrome, it will be flat. So you can test that. There are motor tests for the median nerve. You can see the abductor pollicis brevis muscle, the adductors acting. So you can do the test for that and see if there is a motor dysfunction also. That is in the very late stage of carpal tunnel syndrome. So once you have a clinical test, clinical diagnosis, you would do a diagnostic test for confirming your diagnosis. This is purely for confirmation. So the first thing is a nerve conduction study. So in the nerve conduction study, what we do is put electrodes and then pass current from the forearm to the fingertip or to the muscle and see the nerve potential, both in the motor and the sensory nerve potentials. And you're looking at the conduction velocity as well as the amplitude. So this is done in our neurology OP. So you get a graph like this. So the current is passed from here to here, and the time taken is noted as well as the amplitude is also noted. So based on the kind of graph that you're getting, you arrive at a diagnosis of a mild, moderate or a severe compression. For easy understanding, normally it is about 3 milliseconds for the current to pass from here to here. But in a severe carpal tunnel syndrome, it's more than 5 milliseconds. And anything in between could be a mild or a moderate. And you can also do an ultrasound. Normally, if you see the cross section of the median nerve, it is about 9 to 10 millimeters, but it is increased in the cross section in a carpal tunnel where there is compression. You can see that the nerve is compressed. The shape of the nerve itself has changed. Okay, so far am I clear? You're able to understand what is carpal tunnel, what is carpal tunnel syndrome, and how to diagnose a carpal tunnel syndrome. Okay. Now, as you all know, the carpal tunnel syndrome doesn't come directly to me. They go to the general practitioner, they go to a general physician, they go to a neurologist, and only then after going around, it comes to me probably in the late stage when it's based on the severity, we form the treatment. The early stage, that is when the symptoms are mild, and when the nerve conduction study shows 3 to 4 milliseconds of delay, we do just splinting at night. There are splints for carpal tunnel pain. It's available in our pharmacy. Just the wrist splinting, even if it's only for the night, is sufficient to manage mild carpal tunnel syndrome. And you can wait. If it progresses, then you go on to the next line of action, or you can continue with the splint. Okay. So there are medications, there are activity modifications. These will also help in the progression of a mild carpal tunnel syndrome. When it goes to the moderate level, that is when the nerve conduction velocity is more than 4, you have to go for what is known as a steroid injection. So in the carpal tunnel, I said, if you remember when I told you the cause for the compression is the swelling of the tendons. So there is fluid, there is retention of fluid there. So to reduce the fluid, you give in a steroid injection. So the action of the steroid is to reduce the inflammatory process happening in the tendons. So that reduces the compression on the nerve. So the injection has got nothing to do with the nerve. It has got something to do only with the tendons, not with the nerve. So steroid injections can reduce the inflammation, swelling in the carpal tunnel, and because of which the compression is reduced. So this is not only therapeutic, it's also diagnostic. Sometimes we don't know if it is really carpal tunnel or it's something else. But when you give a steroid injection and there is a relief of pain and symptoms, then you know it is carpal tunnel syndrome. And the steroid injection unfortunately works for 3 to 6 months. After that, the whole thing starts again. You can either repeat the steroid injection, which again will last only for 3 to 6 months, or you can go for surgery. So the surgery for carpal tunnel is the carpal tunnel release. So as if you remember, the base is formed by the bone. You have the transverse carpal ligament coming on the top. So you have to release the tension, and to do that, the simple way is to release the ligament, open the ligament, then you release the tension. So that is the basic principle. So you go in, you just have to cut the transverse carpal ligament and leave it open. So severe cases where the nerve conduction velocity is more than 5 milliseconds and there is a failure of conservative management, you go for a carpal tunnel release. So this is done typically under local anesthesia. It's done under local anesthesia. You can give a median nerve block and an infiltration over this area. Then you incise the skin, incise the palmar fascia, then you will see the transverse carpal ligament. You incise the transverse carpal ligament completely. So anatomically, the transverse carpal ligament extends from the palmar arch down to the antecubital fascia. So the cubital. So this is the incision. That's about 2.5 centimeters of transverse carpal ligament. That's all you have to cut. It's a straightforward cut and stitch. So after you're done, sometimes you explore inside to see how much the nerve is compressed, whether there is any foreign body or any other thing compressing there, and then it's closed. Only the skin is closed. The ligament is not repaired. The skin is closed. So why do we need the transverse carpal ligament? Anybody wanted to answer that question? And we are cutting it off. Why do we need the transverse carpal ligament in the first place? Anybody want to answer that? So if you see the muscles, you have the forearm muscles and you have the tendons going to each arm. Okay, so it's like a bow, like a bow and arrow, like a bow. So if you flex, and if there was nothing holding it back, the tendon would fall forward, like a bow. When you straighten it, it would come here. So to hold that tendons in, you need some restraint, and that is the function of this transverse carpal ligament. So now you can ask, if you cut the transverse carpal ligament, will it not bow? Okay, that is why you have this recovery. So during this recovery, there is scarring, and there is a loss of grip strength, significant loss of grip strength in the initial phases. But as you progress over a period of time, the grip strength comes back. In fact, most people who had symptoms have such a poor grip strength that even with the loss of the transverse carpal ligament function, the grip strength improves. You get my point? If you were to do it for a normal person, the grip strength would decrease. But if you're doing it for a severe carpal tunnel syndrome who already had a low grip strength, it's going to become better only. So there is some grip strength loss, but for that patient, it's going to be actually better. So the recovery, 2 weeks we remove the sutures, then 3 to 4 weeks we gradual return of work and lifting over 6 to 8 weeks. And by 6 months, they have complete recovery of the sensory defects. But people who come in the late stages who have severe muscle atrophy, the muscle is not going to recover, because once the muscle is dead and it's not been taken care of, even the carpal tunnel release is not going to save the muscle recovery. So how do we prevent this? In the modern age, where people are working on the desktop, the posture, it is not only for the back and neck, it's also for the hand. So the neutral wrist position with the hair, sometimes you have seen some people who have been working in the keyboard for a long time, they have a cushion there. So those things help prevent carpal tunnel syndrome. So here is an example. One of the common occupations that I found in my practice here is that milkmaid, people who milk cows for long, 30 years, 40 years, 50 years, they've been milking cows. They develop carpal tunnel syndrome. That's a very unique thing for our setup here. I've seen many patients who are milkers who come with carpal tunnel syndrome. So that is the occupational hazard which I was mentioning. So there's this lady who had 6 months of numbness, waking up at night because of the pain, milking cows for over 40 years, positive clinical examination, positive NCS with severe carpal tunnel syndrome. So an outpatient carpal tunnel syndrome, outpatient open carpal tunnel release was done. It is done, I do it as an outpatient procedure. They come in the morning, go in the evening. It's done under local anesthesia. And they're back after 2 weeks for suture removal, and they're back to work after that. Thank you.
Thank you, sir, for a very nice illustration on the common problem. So questions, please. So while we take up the questions, Dr. Nagendran, can you load your slides? Questions? So I guess the last patient started milking at the 12 years of age, did not go to the school. Age is 52, 40 years, so did not go to the school at all.
Does it occur in both hands simultaneously sometimes?
Yeah, usually it is bilateral. Tube. Physiological conflict, but it's usually bilateral. And when we operate the one which is more severe first, and then we wait for 3 months and operate the other hand. Never do both hands at the same time.
In the absence of nerve damage, are the chances for recovery 100%, and are any chances for redoing the surgery?
So there are two things. One is the severity. If it is a severe carpal tunnel syndrome, but the muscles are not paralyzed, then there is a 100% recovery. If the muscle paralysis is more than 18 months, that is 1.5 years, then the muscle is not going to recover, whatever you do. The sensory part will recover, the muscle part will not recover. Between 1 month and 18 months of muscle death, there is a good chance of muscle recovery, but it may not recover. Because the action potential for the neuromuscular junction has to keep the muscle alive, and if it's not there for more than 12 to 18 months, the muscle will die. Muscle will fibrose.
I happened to see a patient who had undergone carpal tunnel release once, again undergoing the same
It's
procedure
very
in
rare.
one operation theater.
It is very rare. The most common reason for a recurrent carpal tunnel syndrome is where the first surgery was not done properly. That is all I can say, because it should not recur. And some cases, like severe rheumatoid cases where there is severe inflammation, you have to do what is called as an extended carpal tunnel release. What I showed was a mini open carpal tunnel release. You have to go into the forearm and you have to do a synovectomy.
Have you ever seen it in a pediatric patient? I have never seen.
Pediatric patient is possible if they have a ganglion. I have seen pediatric patients. The reason is there is a ganglion which is found on the ultrasound. When we send them for ultrasound, along with the nerve compression, they will mention that there is a ganglion in the carpal tunnel area. So some of the ganglions occur within the flexor sheaths, and because of that, there is a compression. So at the time of release, you have to remove the ganglion also. That is an additional thing.
Suppose a patient is right-handed person and needs a hand reading, undergoing right carpal tunnel release. What is the return of the hand movement dexterity on the long run? You said it will improve. Just said.
No, the motor function loss is mainly in the form of weakness. That is key pinch. That is the one which is affected the most because of the thinner muscles. So the key pinch is, writing is usually not affected in severe carpal tunnel syndrome also. If it is affected, then it has gone beyond the stage of your carpal tunnel release is probably not going to help.
A good presentation, Dr. Bhagavath. Is decurvent tenosynovitis a similar problem but without nerve compression?
Now, as I mentioned, there is a compression here. Like that, there can be compression anywhere. The second common area of compression is in the pulley systems. That is what is causing the trigger finger. So most people who have this will also have this, or it will come at a later stage. And similarly, decurrence is also in the first compartment, extensor compartment. So that is also, basically the thing is the tendons are getting bigger, they are getting swollen. So wherever the tendons are going through a tight channel, it is going to cause a compression syndrome. So it could be decurrence, it could be trigger, it could be carpal tunnel, it could be cubital tunnel, etc. It's all the etiology is the same.
What repeated motion precipitates decurrence?
It is repeated motion precipitated, yeah. That is typically decurrence, they say, when there is a newborn and the grandmother picks up the newborn repeatedly like this. That movement causes the recurrence. So this movement, so classically you do this movement. And another thing, not in India but in Britain, the dart throwing. They do darts in the pubs. So keep repeatedly throwing these darts can cause a recurrence.
Thank you.
But decurrence is the problem outside carpal tunnel, no?
It's outside carpal tunnel. Basically, the problem is.
So it is a mimic.
It is a swelling of the.
But even then, it has pain, but it has no sensory and motor component. No?
Because there is no nerve there. There is no nerve there.
No. So only so it can be called as mimics. Cannot be put under carpal tunnel.
Yeah.
Any more questions?
Sir? Yes, sir. Hypothyroidism again causes edema of the tissues. And there is edema of the tendon sheaths and the tendon as well.
Yes.
Yeah,
yes,
it will disappear.
Yes, sir.
It will disappear.
Good disease.
It will disappear. No, the pregnancy many people develop carpal tunnel during pregnancy. We treat it conservatively. After the child is born, the carpal tunnel gets better. Yeah, it will get better. You can always go through this. But if it goes to a severe stage, then it's better to operate. Sir?
but maybe the duration matters, I think.
The duration. If the nerve damage is beyond the stage of repair, then you have to.
Yes. So, any more questions? So, no more questions. We thank you.
One last thing, I want to acknowledge Dr. Ramdas, late Dr. Ramdas, neurologist, who sent more than 100 cases to me of carpal tunnel. It was a hectic practice for him with a lot of carpal tunnels, and he used to refer a lot of cases. Really miss Dr. Ramdas today.
Thank you, Dr. Bhagavath Kumar, sir. So, next presentation is going to be from Dr. Nagendran, Myositis mimics.
Good morning, everyone. Today I am going to talk about this topic, myositis or mimics. So we have two case scenarios. The first patient is a 71 years old male, was treated elsewhere for adenocarcinoma of stomach with chemotherapy, capecitabine and oxaliplatin. The symptoms started after the first chemotherapy cycle. He developed swelling and weakness in the left upper limb and lower limb. The swelling, it gradually progressed to massive size like a lymphedematous swelling, along with development of scrotal edema and anasarca. And the weakness, there is a progressive weakness eventually leading to a bedridden state. There is no sensory disturbance at that stage. So they thought the provisional diagnosis might be due to a chemotherapy induced neuropathy or myopathy or cardiotoxicity, and meds also was considered at that time. So they did these investigations. Nerve conduction study was normal, MRI was normal, muscle enzymes were normal, and echo was also normal. So they have gone for PET CT. PET CT, it showed there is increased uptake in left arm muscles and left thigh and gluteal muscles only, with diffuse subcutaneous edema. So a possibility of paraneoplastic myositis was considered. They have done autoimmune workup, and ANA profile was negative, and myositis profile was not done. So with the evidence of PET CT, they have started him on IV methylprednisolone for 3 days, followed by dexamethasone. Even after 10 days, there is no improvement of the muscle weakness with worsening. So they referred here for our institution as steroid refractory paraneoplastic myositis. At the presentation, the power was 1/5 in left side and right side 3/5. There is gross edema on the left side of the body in upper limb and lower limb. Might be a lymphedematous swelling, and anasarca and scrotal edema was also there. So the initial laboratory results shown mild to moderate anemia and thrombocytopenia and hypoalbuminemia. Renal and liver functions were normal. We repeated CPK here and other muscle enzymes also. Everything was normal. So what is the diagnosis? At this stage, to summarize, there is asymmetrical muscle weakness in the left side of the body and asymmetrical swelling in left side of the body with normal muscle enzymes, and PET CT shown increased uptake in left side of the body only. So at that time we suspected it might be due to chemotherapy induced myopathy, because the symptoms started after the first dose of chemotherapy, and myopathy per se doesn't need increased muscle enzymes, only the muscle uptake will be increased in case of myopathy. The second diagnosis DDS is paraneoplastic myositis. Paraneoplastic myositis, the steroid refractoriness and the cancer before the onset of myositis as well as the age, it supports paraneoplastic myositis. But the normal muscle enzymes and asymmetrical pattern, it argues against paraneoplastic myositis. Or it can be a simple lymphedema. Lymphedema, it can be due to a cancer or per se due to the chemotherapeutic agents. So but the weakness is not explained by lymphedema. So we did an MRI to confirm whether there is myositis is there or not. So in the MRI, there is diffuse hyperintensity involving all the muscles of anterior medial compartment of left thigh and left gluteal muscles, but the posterior compartment muscles as well as rectus femoris is relatively spared. and there is diffuse subcutaneous edema is there. So even in the single limb there is asymmetrical pattern of involvement. And CT of left arm, it also showed that there is diffuse edema in muscles and subcutaneous tissue, and anterior and posterior compartment muscles are edematous and swollen with areas of calcifications were there. At that time radiologically it mimicked the early stage of myositis ossificans. So with this imaging also we just confirm the earlier findings. We are unable to arrive at a particular diagnosis. So we did a muscle biopsy. It showed course of skeletal muscle fibers infiltrated by neoplasm arranged in cords, clusters and singles, and there is focal background Muse impulse. So it is a metastatic poorly differentiated adenocarcinoma with signet cell differentiation. So the lymphedema might be due to the mucin pool accumulation. So the hyperintensity, T2 hyperintensity in MRI, it just reflects an increased water content. It can occur both in muscle necrosis that causes raised CPK levels as well as without cell wall damage. This usually occurs in hypothyroidism or drug induced causes. This won't cause any mild to normal to mild elevation of CPK only. So as far as cancer associated dermatomyositis is concerned, so these are the points which should make us suspect a case of cancer associated myositis. It is age more than 45 years, rapidly progressive muscle weakness, skin ulcerations, and anti-TIF1 gamma and NXP2 positivity in muscle antibodies and steroid refractoriness. So the second case, it's a straightforward case. A 28 years old female presented with proximal muscle weakness of upper limbs, neck and lower limbs. The upper limb weakness is more with 3/5 and lower limb is 4/5. There is no sensory disturbance at the onset. As other system examination, there is only a palatal ulcer without any skin lesions. So lab examination revealed CPK levels of 265, LDH 355, that is minimally raised CPK and LDH, and blood counts, renal and liver function and urine abnormalities. Urine shown no abnormalities. So at this stage either a CTD associated myositis or a proximal myopathy due to a muscular dystrophy was considered. CTD associated myositis, why it is a CTD associated myositis rather than idiopathic myositis? Because there is certain features that suggest a SLE myositis rather than IAM. Sir, in SLE there will be pain more than weakness and other SLE clinical manifestations will be there, and CPK will be only mild to moderate elevations will be there and disproportionate CPK elevation. In this patient there is palatal ulcer which is suggestive of SLE was there, along with only a mild CPK elevation and disproportionate CPK elevation. And as far as myositis is concerned, weakness will be more than pain and extramuscular manifestations like Raynaud's arthralgia will be there, and CPK will be more than 10 times of upper limits of normal and proportionate CPK elevation will be there. So we did an autoimmune and metabolic workup. Autoimmune workup showed ANA nucleola 3+, but other investigations ANA profile, C3C4, anti-dsDNA, everything was normal, and myositis profile was also normal. So to rule out metabolic mimics, hypothyroidism and hyperthyroidism were ruled out and hypokalemia was ruled out. So we did a muscle biopsy. It's shown limb girdle muscular dystrophy proven with light microscopy as well as IHC. So to conclude, when to suspect myositis mimics, there should be a distal myopathy or asymmetrical weakness, episodic myopathy, exercise intolerance with cola colored urine, neurological signs, family history of myositis, endocrine history. If these points are there, we have to suspect a myositis mimic rather than a myositis, and muscle biopsy is the gold standard. So not all muscle edema and weakness represent inflammatory myositis, and normal or mild elevated CPK we should reconsider the diagnosis, and steroid refractoriness, it is a key red flag sign, and imaging, it only guides the biopsy, and follow-up scan will reveal the prognosis, but histopathology is definitive. And muscle biopsy should be pursued early when clinical signs are atypical. Thank you.
Thank you, Dr. Nagendran. Very interesting patients. So finally, went to the biopsy and got the nail done. My question, any more questions?
In the first case, was PET CT done?
Yeah, yes, sir. Yes, sir. Yes, sir.
It didn't
They have
show
repeated
any
twice.
increased uptake.
Yeah, they have.
Oh,
Yeah.
So my question is, the first case, how to call it as dermatomyositis? It can be paraneoplastic. It can be. It's dominant. There is no skin features.
Yeah, but
Even though
usually-
malignancy is one of the important leading cause for dermatomyositis.
biopsy only will help to differentiate, sir. And unless otherwise, there is other cutaneous manifestations of dermatomyositis. And in this other types of myositis like immune mediated and inclusion body, everything, polymyositis, there won't be any skin ulcerations. Skin ulcerations is there, we should suspect in a malignancy associated myositis.
Okay, so in the second case, the limb girdle dystrophy,
Yeah, the first-
you are thinking due to the CTD or evolving lupus or in isolation?
Palatal ulcer, if it is there, it 90%, 95% lupus is the diagnosis. But at the disease onset itself, she was admitted under Dr. Aruna ma'am. She was thinking of facioscapulohumeral dystrophy because only the upper limb muscle weakness was there. Lower limb, it is nearly normal, 4/5. So she was thinking about this muscle dystrophy at the disease onset itself.
No, my question is, your point is due to SLE or not due to SLE?
SLE.
So, any questions?
Potassium.
Yeah, yes, sir.
It's a very common abnormality which we tend to miss, particularly when we use more of a proton pump inhibitor, steroids as an inhalational agent. The borderline reduction in potassium can lead to some increase in CPK with a florid muscle weakness. And this is all the more important when there is a hypertension where this could represent a hyperaldosterone states. And the point here is again the steroids. This fluorinated steroids like beta and dexa are more prone to cause this muscle weakness than this non-fluorinated steroids. So looking at potassium, also magnesium side by side forms the most important part of the workup as it is.
So, any questions? So, if there are no more questions, we thank Dr. Bhagavath Kumar sir and Dr. Nagendran for their excellent presentation, and thank you all. We'll meet you on the next clinical meeting. Thank you all.
Thank you, sir.